experience sharing with us. And I hope that we will enjoy, as usual, listening to you and learning from all of you. Um, uh, I would like to welcome Dr. Abishali, Dr. Prasan, Dr. Patricio, Dr. Gridhar, Dr. Majdi, Dr. Shabit, and also Dr. Fahad Kuhel. He will join us later. And now we will start having the first presentation. It will be as a symposium for Novartis. It will be presented by my dear friend, Dr. Prasan Ram. Dr. Prasan, mic with you. Now we are almost 23. Go ahead.
Uh, are my slides seen?
Yes.
Okay. At the outset, let me thank Dr. Ambri and Novartis for giving me this opportunity to speak. I'll be speaking on BioView, a next generation anti-VEGF, which is indicated for the treatment of age-related macular degeneration. So as we are all aware, age-related macular degeneration is the leading cause of severe and irreversible vision loss worldwide. And 90% of the visual loss occurs due to wet age-related macular degeneration, which is characterized by the growth of pathological choroidal neovascular membranes, which grow under the retina, leak fluid, blood, and eventually cause damage to the photoreceptors and loss of vision. So wet AMD is a chronic condition which is characterized by retinal fluid accumulation, and the presence of fluid damages the retinal structures. So fluid accumulation is a major concern for us. Over the past few decades, with the evolution of the imaging system, the treatment modalities for wet age-related macular degeneration have changed. Initially, we used to do observation, then we started with thermal laser, submacular surgery. In the early part of the century, we had photodynamic therapy with verteporfin, which stabilized the disease, but there was no visual improvement. And finally, in 2005, we had anti-VEGFs. So anti-VEGFs are the latest advances in the management of wet AMD. And these anti-VEGF have been tried and tested in various clinical trials, and they have demonstrated efficacy and safety as well. So in 2006, we had the pivotal registration trials for ranibizumab, that is Anchor Marina. And 2012, we had the registration trials for aflibercept, and so on and so forth. So with the introduction of the anti-VEGF, we also realized that the prevalence of blindness due to wet AMD has been significantly brought down. So a lot of patients who used to be legally blind, if you look at the green bars, these were before the era of anti-VEGFs. As compared to now, they are much lesser. Similarly, eyes which had moderate visual impairment and mild visual impairment had significant improvement after the anti-VEGF therapy. However, patients with age-related macular degeneration have a lot of treatment burden. They are expected to come periodically to the clinic on regular basis, require medication and injections on periodic basis and multiple period of times. So survey looked at patients with wet age-related macular degeneration, and they found that for one particular visit, the patient had to spend a mean time of over 12 hours, which included preparing for the appointments, travel, waiting, and undergoing the treatment. And the most concerning part was 72% of these patients required the caregivers to drive them to the appointments, which also added further burden, not only to the treatment, but also for the other relatives or the kin next to kin of these patients. So we know that fluid in wet AMD is an important disease activity marker. So we look at intra-retinal fluid, sub-retinal fluid, and sub-RPE fluid. And controlling fluid is key to effectively treating wet AMD and also maintaining and improving vision. So anti-VEGFs, as we all know, inhibit the formation of the new vessels, and they stabilize the disease as well as the morphology of the retina. So let's look at BioView and the clinical trial, which is the registration trial for BioView. So what is BioView? BioView is a humanized monoclonal single chain antibody fragment. And what is a single chain antibody fragment? It is the smallest unit of any antibody, but this molecule retains the full binding capacity to its targets, which is all the isoforms of VEGF-A. Now, please note that because it's a small molecule, the size is very small as compared to the other molecules. So it is about 26 kilodaltons as compared to 115 kilodaltons for aflibercept. Because of its small size and because it is masterfully engineered as an anti-VEGF medication, in a small volume, it contains more binding agents. So it has larger molar concentration of the drug as compared to its competitors. This also maximizes the ability of the medication to bind to VEGF, and it is It has 12 times more molecules than aflibercept for the same volume. And it has a high potent and high affinity binding to all VEGF-A isoforms. So because of its size, it also has a better penetration into the retina and into the RPE. And as we all know, all the diseases of the age-related macular degeneration, the cause is in and around the RPE. The half-life of Beovu is also around 57 hours as compared to the other medications. So let's look at the pivotal trials, the Hawk and Harrier. The Hawk and Harrier is a 2-year randomized double-masked active control multi-center trial, which was conducted in 408 sites in Northern, Central, Southern America, and the Europe, Asia, Australia, and Japan. So these are the primary endpoints. So the primary hypothesis was to look at the change from baseline in visual acuity to week 48 measured on the ETDRS. And the primary objective of both the Hawk and Harrier trial was to demonstrate that Beovu Q12 and Q8 is non-inferior to fixed dose aflibercept with respect to change in visual acuity from baseline to week 48. Please note that this was a registration trial, hence the fact that it was to be shown that it is non-inferior to fixed dose of aflibercept. The secondary selected endpoints were proportion of patients on Beovu who were maintained on Q12 interval following the loading dose through week 48. Disease activity status at week 16. I'll tell you the importance of week 16 later. And the central subfield thickness from week 16 and at week 48. And also the number of patients on Beovu at Q12 treatment. And finally, the reduction in the fluid. As we all said, fluid is a very important thing. So this is at week 16 and week 12. The inclusion and exclusion criteria was pretty standard for any registration trial for age-related macular degeneration. So the patients more than 50 years, active CNVM involving the center, and with a visual acuity of 78 or 23 ETDRS letters. Exclusion criteria was if the patient should not have any intraocular inflammation, any fibrosis, geographic atrophy, subretinal hemorrhage involving the fovea, and finally, any history of evidence of concurrent intraocular conditions, which would interfere with the assessment of the drug. These are the baseline characteristics. So if you look at the baseline characteristics, they were well matched between all the groups, between the 6 milligram of Beovu and the aflibercept, both in the Hawk and Harrier study. Also, an important point to note, the visual acuity was in the range of about 60 ETDRS letters across all the groups. And this is usually the reflective of our clinical practice. If you look at the clinical trial, the way it was designed, it's the first prospective head-to-head trial with Q12 interval immediately after loading, comparing Beovu and aflibercept. So it had two phases, the matched phase and the maintenance phase. Now, the importance of the matched phase was, in this match phase, both the patients in both the arms were given injection at week 0, week 4, and week 8. And following this, there was an 8-week observation period, and at the end of which, week 16, the first disease activity assessment was done. So in both these groups, the patient had the same number of injections, so we could compare them head to head in the first match phase. In the subsequent maintenance phase, in the eyes which were treated with aflibercept were given injections every 2 weeks as per label. With eyes in the Beovu groups were given injections every Q12, that is at week 20, 32, 44, 56, and so on. But also disease assessment was done in Beovu patients at 16 weeks, 20, 32, 48. At any point of time, the disease activity showed that the patient has an active disease. The patients on Q12 were shifted to Q8 dosing. So they were brought down to a shorter duration of treatment interval, and they were maintained at Q12 throughout the phase. So there was no option of increasing like we do in treat and extend. Similarly, the assessments were done at various phases. Also note that in Harrier, there were additional disease activity at 28, 40, 52, and so on. Now, what were the disease activity assessments which were done? So at week 16, we looked at, there were 4 criteria: the decrease in visual acuity of more than 5 as compared to baseline, and the decrease in base corrected visual acuity of more than 3 letters, plus a CST increase of about 75 microns compared to week 12, decrease in visual acuity of more than 5 letters compared to week 12, and new or worse intraretinal fluid or intraretinal cyst compared to week 12. So if you look at disease activity assessments, the way we do it in our clinical practice as well, you had the functional outcome, which is the visual acuity, and the anatomical outcome on the OCT, which is intra-retinal fluid, subretinal fluid, the CST, and the sub-RPE. So let's look at the functional and the anatomical outcomes in these trials. So in the Hawk and Harrier trial, BOView clearly demonstrated a robust visual gain. So if you look at week 48, clear, BOView clearly demonstrated a non-inferiority to aflibercept, as was the primary objective of this study. Also important to note that at week 48, more than 50% of the patients on BOView were at Q12 interval. And these similar results can also be seen at week 96. So BOView clearly demonstrated that the patients initially had a good improvement and they had sustained and maintained vision throughout the time period of the course. If you look at the fluid response, BOView outperformed aflibercept with significantly fewer patients with intraretinal and subretinal fluid. Now note I told you about the importance of week 16. So at week 16, where the patient had the same number of injections, there was further reduction in subretinal fluid in the BOView group as compared to the aflibercept group. So 35% lesser patients had fluid. And this is important because this clearly demonstrates the long-term benefit or the enhanced efficacy of the medication in terms of duration, as well as reduction of the subretinal fluid. Similar responses were noted at week 48, and a similar response was even noted at 96. So over a period of 96 weeks, BOView outperformed aflibercept, both in terms of reduction of the intraretinal and subretinal fluid. If you look at the central subfield thickness, if you look at this curve, BOView showed a reduction, superior reduction to central subfield thickness at week 16. Again, this is the match phase. And this continued at week 48 and even at week 96. Classically, if you see this classic sawtooth pattern of aflibercept, which has been demonstrated and seen even in U1 and U2 studies. If this is one of the patients in the BOView group, this patient had a visual acuity of 65 letters and a central subfield thickness of 498 microns. And at week 96, you can see a significant improvement in vision by about 20 letters and a reduction in the central subfield thickness. When this patient was maintained on medication, at week 96, he maintained the same visual gains at week 16 and also a dry macula at week 96. What happens to the subretinal fluid? Now, in patients treated with BOView, again, there was a significant reduction in the subretinal fluid at week 16 and at week 48. And lesser number of patients had subretinal fluid as in the aflibercept group, in the BOView group as compared to the aflibercept group. And similar results can be seen at week 48 and at week 96. So finally, if you look at disease activity, as I mentioned in the past, the clinical features, the measurements we do are functional in terms of vision and the anatomical outcome. This is at week 16, again, when the patients had the same number of aflibercept and BOView injections. The eyes with the BOView had lesser disease activity as compared to the eyes with the aflibercept group, both in the Hawk and the Harrier trials. And this was statistically significant, again demonstrating a significant improvement in terms of the treatment intervals as well as the efficacy of BOView over aflibercept. And also important to note that the majority of the patients were maintained on Q12 immediately after the lowering dose, and this was seen throughout the week 48 in the first 1 year. That means more than 50% of these patients were requiring injections at Q12 interval in this phase. This is one study which also looked at the probability of how the patients would behave when they were on Q12 injection intervals. So under a condition where the BOView patients had no disease activity on 12-weekly dosing, the probability that these patients would remain at 12-week interval injections from week 12 to week 48 was almost 85 to more than 80% in both Hawk and Harrier. And this is at week 48 in the first 1 year. And similarly, another similar probability of maintaining the same Q12 intervals in the second year. So this would tell us that there is a 4 out of 5% chance that the patients, if they are on Q12, they would maintain the same Q12 for a period of 2 years. Safety profile, BOView exhibited overall well-tolerated safety profile in Hawk and Harrier. However, in the early part of 2020, there were some reports from the ASCRS Research and Safety in Therapeutics Committee mentioning that there were some patients who developed intraocular inflammation and especially looked at retinal vasculitis. as well as retinal vein occlusion. Novartis appointed an independent safety review committee, which looked at patients who had inflammation both in the Hawk and Harrier group, as well as patients who developed the problems in the post-hoc period. And they found that the incidence of these adverse activities per 10,000 patients was very less. For example, if you look at retinal vein occlusion, it was about 2.35 in 10,000 patients. If you look at retinal vasculitis, it was around 3, and almost about 4, less than 4% had both retinal vein occlusion and vasculitis per 10,000 patients. And if you look at the percentage of patients having loss of vision, that was less than 1% compared to the whole group. And also they found out that the incidence of both the vasculitis and the vein occlusion were similar between the BOVU and the aflibercept group. So having said that, we know the efficacy now. The BOVU has now been approved by the FDA as the only anti-VEGF medication, which is eligible to be injected every 12 weeks immediately after the loading phase. It's available as a single-use pre-filled syringe. And fortunately, I had the opportunity to use this medication in 2 of my patients last week. They are doing well in the first 1 week. Let's see how they respond at the end of about 3 to 4 weeks after the injection. So in these 2 head-to-head trials, the Hawk and Harrier versus aflibercept, BOVU demonstrated robust visual gain. It outperformed aflibercept with superior fluid resolution, and majority of these patients, more than 50%, were on Q12 interval immediately after the loading dose, and it also exhibited an overall well-tolerated and safety profile. Thank you very much for your kind attention.
Thanks a lot, Prasan, for this an excellent presentation about the new drugs that we are waiting also for all new drugs that can help us to treat our patients, especially in this special disease that we are leading to a blindness in most of our cases. If there is any question or comment for Dr. Prasan? Anyone have any experience or chance to try this medication? I have actually a chance also to try this medication now before 3 months almost now. Almost I have done one patient and he finished the 3 loading dose in one eye. And I have presented that one times that response is actually, I didn't anticipate even that response. Within the first week, there was a complete dry of the macula. Even it was about, I think, if I do remember, 700, if I don't mistake. So really is now we are all the times we are getting new drugs that can give a hope for our patient in improvement the vision and also to treat this kind of disease. Thanks a lot, Dr. Prasan. And I would like now to introduce our doctors, Dr. Vishali Gupta, and she is going to talk her talk. It will be about relevance of fluid in neovascular AMD. We get permission from all of you because Dr. Vishali, we won't want to delay her more, but we are hoping that maybe she will stay with us even after she give her presentation. Dr. Vishali, mic with you.
Thank you. Thank you, Dr. Amri. Thank you, everyone. And thanks a lot, Middle Eastern Society, for giving me this opportunity to speak to all of you. So we heard a beautiful talk by Dr. Rao where he showed that brolucizumab was more superior to whatever we have because it dries the fluid. So now comes the question, why fluid? So when we look at the anatomical markers, we started with fluid, Schramm, hemorrhages, and long time ago we started with fluorescein. However, these are the kind of the markers which we all are used to of seeing on OCT. We look for the presence of Schramm, we look for the fluid, we look for sub-RPE fluid. Now let's talk about the story of the fluid. Fluid became a very important part of our lives when we started with lot of trials. Now, if you go over these different trials, you see, all of them were actually treating the patients based on the presence of the fluid. So fluid became so important that over a period of time, we stopped even bothering doing the fluorescein angiogram because we were just looking for the presence of fluid on OCT. So we started with time domain in previous, then we moved on to swept source, and though the trials yet do not have, they used mostly the spectral domain, but we have moved on even to the swept source. So did the trials actually show that no fluid had better visual gain? So if we look at the past trials of CAT and View 1 and View 2, actually they did not show that there was much superiority of having a bone dry macula over something which had a little bit of fluid. However, those trials did not differentiate with different types of fluid. So now let's look at what are the types of the fluid which we can get. From what are the types of the diseases? We do understand there is a lot more to kind of the fluids that we see, and you may have SRF drape, which is just next to the PD, like here one. You may have the fluid over a scar, or you may have outer retinal tubulations, which in past sometimes were mistaken for the presence of fluid. So should we consider different types of fluid differently when we are giving prognosis to the patients? So let's just quickly go over what are the various types of fluids. So we see this fluid which is under the RPE, and this is one of the earliest fluids to come and one of the earliest signs of active disease. This then goes on to subretinal fluid, and finally you get the fluid in the cyst forms of retinal cyst that is within the retina, and we call it intra-retinal fluid. As you can see by the sequence of the event, this fluid, intraretinal fluid, this is the one which is causing neurosensory functional deficiency because it is actually causing the degeneration of the neurosensory retina and is responsible for significant visual loss. So we look at the fluid for making the diagnosis, for deciding time to treatment, for treatment interval, and finally visual outcome. Now let's see what the trial said about the fluid. Now Saylor and Harbour in the beginning said detection of the fluid was important because if you detect fluid, you treat in time and you have better visual outcome. Let's start with the intraretinal fluid. Now, intraretinal fluid actually is a bad guy here. If you see these cysts. Now, if these fluid cysts are present at baseline, patient is going to have a poorer visual outcome. If these cysts appear during the course of the disease or they persist, even then the outcome is going to be poorer. So let's have a look at intraretinal cyst. This is the post-hoc analysis of view 1 and 2, which very clearly says that if your patients do not have intraretinal cyst at the baseline, they are going to have a better visual response following anti-VEGF therapy. Again, we continue with the secondary analysis of CAT study, which mentioned that if intraretinal fluid persisted, that was associated with poor visual acuity outcome, even when you keep on treating it with anti-VEGF. Post-hoc analysis of EXCITE study shows that if the new intraretinal cysts develop after you have given the loading, it again means a bad news because your patient is going to have decline in the visual acuity. So intraretinal fluid, we all understand, is a bad guy. So what about the subretinal fluid like this one? Actually, some studies have indicated that if you have subretinal fluid only at the baseline, or even when you treat it and you are left with a little bit of subretinal fluid, these eyes are the ones which are going to have better or stable visual outcome. Which means, in short words, if you see the subretinal fluid for your patients, you should feel happy because these are the patients who are going to respond better to your treatment. Now, what do the trials say about the fluid? The VIEW study, when it did the secondary analysis of the fluid, it said that if you have SRF at the baseline, it honestly does not affect the initial visual acuity, and your results following the anti-VEGF treatment are going to be relatively better. Secondary analysis of CAT study again said that if you have a little bit of SRF present, it does not adversely affect the visual acuity outcomes during anti-VEGF treatment. Ancillary study of EXCITE said repeated recurrences, however, can result in poor visual outcome. So it means that though the initial studies did say that some SRF was fine, but you can't have it go on and on because the cliche here is that SRF should not be allowed to persist for very long. Now, fluid study was a very interesting study. What they did, they treated the patient with anti-VEGF and they divided it into two groups. The one group, they did the complete drying, which they call the intensive arm. The second was relaxed group, like if you had SRF, which was less than 200 micron, they did not push on by giving more and more injections of aflibercept. So let's see what happens here. I will show you the results of the trial later, but I will just show you an example of a patient. Now, we look at this patient. We look at the beginning and there is subretinal fluid. So reading from my studies and my trial and experience, I think this is the patient who has good prognosis because he doesn't have any intraretinal cyst. So you give 3 loading doses, he is doing very well, and you keep him on follow-up. The fluid is not coming back. He has improved vision. So this is what we expect, the subretinal fluid to behave very well. And when they did the fluid study, they divided it into two groups. The one group, they did bone dry, and the second group was more relaxed. So what they found was, although there was no significant difference in the best corrected visual acuity, if you allow SRF and IRF to present in the relaxed group, what I want to simplify for you, if you allow the subretinal fluid to persist for a long time, over a period of time, it can actually develop intraretinal fluid. So per se, subretinal fluid might be good, but you can't let it stay for very long because it might incite the development of intraretinal fluid. And then comes the last of the fluid, which is sub-RPE fluid. Honestly, there have not been many studies which have focused on sub-RPE fluid. And the reason for that was that the initial studies that came, VIEW 1 and VIEW 2, they said the presence of PED does not make much difference on the final visual outcome. But when we looked at the real world scenario, people were paying attention to the height of the PED, to the type of the PED, to the volume of the PED, and people did report that PEDs can be associated with poor visual improvement, and you have to keep a watch on them. So I'm going to show you an example of the case, how these things can be important. So we see here a patient with AMD, and when we do OCT, we realize most of the thing is happening beneath the pigment epithelial detachment. So you can see he has received 2 doses and then he receives more dose, and his pigment epithelial detachment and the sub-RPE pathology, you can see the height decreasing and he's responding, and his visual was kind of stable at 6/9. So the patient was very happy. He did not want more injections and we lost him for follow-up. When he comes back to us, he, no, sorry. This is the patient who did not come back to us and we kept on following him. He was maintained at this. The next example that I'm going to show you is how important it is to keep these patients under follow-up. For example, this patient had a choroidal neovascular membrane. He had this subretinal fluid, and he also, once we started after treating 3 injections, subretinal fluid disappeared, but we had a very small streak of sub-RPE fluid. So patient vision was 20/20. So we lost the patient to follow-up because he thought he was doing very well. So what I was trying to emphasize is that if you have this streak of fluid, or even if you don't have, it's very important to look for the earliest signs of fluid, because what happened to this patient? When he came to us 14 months later, from this little streak of fluid, he had gone on to develop subretinal fluid, intra-retinal fluid with, and which is the bad fluid of all the fluids. So even after post 6 injections, we are not able to bring it back to bone dry. However, if he had followed up and this fluid was reduced, probably we would have been able to maintain him at this vision. So this is my last slide. The story of the fluid continues to evolve. Any fluid anywhere indicates active disease. Fluid resolution, not in the short term, but in the long term, will correlate to visual benefit. Magnitudes may vary. You may have more stable central thickness, which is associated with better visual outcome. And continuing with Dr. Rao's talk, brolucizumab makes sense because it actually helps in drying the fluid. Thank you very much.
Thanks a lot, Dr. Bichali, for your comprehensive and excellent presentation. You take us in a journey in between the fluids in the retina, so we can understand all that. But still, there is one question: are we treating the fluid, or we are treating the cause of fluid? I think this one is still the dilemma. Dr. Majdi, your comments.
I think the fluid is the effect of the cause. The fluid is coming because there is a cause. So if we see the fluid, it means the cause is active, the disease is active. So indirectly, we are treating the disease. Fluid is just the biomarker of underlying pathology, because when we are looking at the choroidal neovascular membrane, we are not looking at the gross era where we would looking for hemorrhages or exudation, which will come at a much later stage. We are nowadays not even doing fluorescein to look at the leakage. What we are doing in practice is looking at the presence of the fluid. And now we are going a step further where we are not even looking at the fluid, we are looking at the character of the vessels on angio-OCT. And if we find there is a change, we start injecting. Because to be very honest with you, the core of the treatment is not to let the disease progress at a stage where it becomes too visible to us. We should be able to treat it when we can preserve that good vision.
Thank you very much, Dr. Victari. Yes, Dr. Shabit, but open your mic, please, Dr. Shabit. You are, okay.
Yeah. Dr. Vishali, the last patient which you showed with type 1 CNV, which went on to deteriorate and develop fluid in all compartments, do you feel that these patients under therapy are patients who are shifting from type 1 CNVM to a PCV-like disease? Because that's what I felt, and that's what I've seen in my experience. Once they are lost to follow-up, many times they return back with PCV features.
Absolutely. So maybe, I haven't looked from that point of view, but that's a very interesting thought that when we are overdoing or overkill, whatever you call it, is it that we are not allowing PCV variety of the disease to go to its full glory? You know, we are just killing it in the incipient stage. And maybe because they come back with a full blown disease and there is a component of PCV, and then you keep on trying, but they really do not work very well. And you may have to add PDTs and things like that, and with not so good a visual gain. His initial ICG did not have PCV, but we did not repeat the ICG. Maybe that would be a good idea. Yeah.
Thank you.
Thank you very much. Dr. Patricio, if you want to comment or introduce also Dr. Majdi, you have any comment?
Yeah, I have a comment. Yeah, maybe polypoid is somehow more prevalent in this area, South Asia. But from the times of PDT, when we were facing type 1 CMV without possibilities of treatment in Europe, but you started to see exudation by transformation from type 1 to a minimally classic type 1 plus type 2 CMV. So maybe for this area, maybe going to polypoid, but for Europe, that's not the case. It's the mix 1 and 2. About the fluid, yeah, I try to individualize very much my patients. I don't mind them keeping some subretinal fluid from time to time. I can follow them. And sometimes I have seen cases with no treatment, just maybe the RPE is not competent enough after several injections and the fluid disappears on its own. I don't really know why, but without injections, the fluid can disappear. As I said, maybe RPE is not competent enough. But yeah, individualization of the patients is, I think, our objective.
Yeah.
Not to go only for the OCT.
Thank you, Dr. Okay, Dr. Majdi.
My comment is, I like the presentation because any intraretinal fluid is harmful for the retina. As Dr. Patricio said, some of my cases are completely dry except minimal subretinal fluid with 6/9 or 6/6 vision. I should not go after this little amount of fluid. I should never. I should leave it, and sometimes they disappear spontaneously without injection. But intraretinal fluid, once you get rebound of intraretinal fluid with cyst, the vision you lost, you will never regain again. So again, you have to keep an eye on the patient. Any intraretinal fluid should be treated. Minimal subretinal fluid can be followed up. Sub-RP fluid is a sign of recurrence. If you get rid of the sub-RP fluid and you find any new sub-RP fluid or hemorrhage, these are signs of recurrence, and I should not wait for injection. This is my comment.
Yeah. In practice, the subretinal fluid of less than 200 micron is supposed to be actually good, because they say your oxygenation and everything for the photoreceptors would work. So what I would do practically for these patients, I will keep them under follow-up. But if they become symptomatic, and you will know that these patients are very, they know. Sometimes they tell you that I'm having the complaint. So I do an angio-OCT, and if I see the change in the character of new vessels, even though my fluid has not increased, I would inject. Because many a times the fluid then keeps on increasing, maybe after a few months. So I guess listening to the patients and close follow-up is very important.
Totally agree.
Thank you very much, Dr. Vichali, and thanks for all panelists for their comments. Now we'll have my dear friend, Dr. Majdi Musa. He will talk about non-responding DME. Dr. Majdi.
Okay. Thank you, Dr. Amri, for the kind invitation. And
it's our pleasure. You are all the time most welcome.
Thank you. Can you see my screen now?
Yes.
I'll try to be short because I know we are running out of time. So my talk today is about persistent or non-responding diabetic macular edema. Let's go in one slide about the pathogenesis of diabetic macular edema. We all know that it is because of disruption of the inner and outer retinal barrier. And we used to think inner retinal barrier is only the endothelial cells inside the capillaries, not only. It is the Muller cells and the astrocytes. So losing this is another factor which lead to accumulation of fluid inside the retina, and the outer barrier, which is the tight junction between the retinal pigment epithelium. With disruption of this will lead to fluid accumulation under the retina and inside the retina. Second thing, release of vasoactive factors or vasogenic factors and inflammatory mediators. We should not overlook these inflammatory mediators because sometimes these hyperreflective foci had an implication of inflammatory or chronicity of the disease. And the last thing in the pathogenesis is the tractional diabetic macular edema, which could be alone or combined with the disruption of the outer and inner retinal barriers. So we have many modalities of treatment in diabetic macular edema, including the anti-VEGF. I didn't mention the view because it's not in Egypt yet. In the intravitreal steroids, we have the triamcinolone, the long time triamcinolone, then dexamethasone implant, and the fluorouracil implant or Iluvien. Sometimes we use combined treatment, and lastly, vitreoretinal surgery could be used in persistent diabetic macular edema, which I don't prefer in my practice. Let's speak about anti-VEGF. We all know that anti-VEGF is still the standard of care in treating diabetic macular edema, and it's mentioned in all clinical trials and DRCR-NET protocols, Rise and Ride, Vivident Vista, Retain, Protocol I, and the published data of Protocol T stated that all available anti-VEGF, the 3 available anti-VEGF, bevacizumab, ranibizumab, and aflibercept are all effective, though they are not equal, but they are all effective in treating diabetic macular edema. So we agree that anti-VEGF is still the standard of care. So what's the meaning of responding or non-responding? Let's put that in few slides. Responder means that it could be a good responder, that more than 40% reduction in the central foveal thickness or central subfield thickness. Moderate responder from 10 to 30% reduction in the central foveal thickness. The poor responders, they have less than 10% reduction, and non-responder, no reduction or even progression in the central foveal thickness. In the persistent diabetic macular edema, we have 2 types, either anatomical or visual. Because anatomical, it means that less than 10% reduction, looking at the OCT and seeing how many microns. But visual persistence means that less than 5 ETDRS letters or 1 line of Snellen of improvement. And we have 2 subsets of this. Poor anatomical response, but visual acuity is improving, and poor anatomical and visual response. Let's go through some cases to know what is the good response and what is the moderate and what is the non-responder. This is a patient with a 687 micron central subfield thickness with sensory attachment. After 4 intravitreal anti-VEGF, we have a completely dry macula. We have central foveal thickness of 200 microns and more than 70% reduction in the central foveal thickness. By the way, this doesn't mean that the vision is completely regained. This patient ended up with 618 vision. Why? Because of the disrupted outer retinal layer. So it's not always anatomical correlated with what we see in the vision, but this is anatomically is a very good responder. When we go to 3 intravitreal anti-VEGF injection and we have more than 40% reduction in the central subfield thickness, it means it's a good responder, and we have to continue injecting this patient till we get completely dry macula. But when we have a patient who had 3 injections and had a moderate response, less than 30% reduction, we should not give up on these patients. We should continue injection, because 2 more injections, we have a good response, and we have to continue on and on. We should not rapidly go to switch to other anti-VEGF. But let's see a patient like this. We have repeated intravitreal anti-VEGF, 3 loading dose, and there is no response. On the contrary, there is increase in the central subfield thickness from 726 to 794. Should we continue injecting this patient with anti-VEGF, the same anti-VEGF? This is a big dilemma. But how often we see such cases? In my practice, it's about less than 5% even, seeing that patients are not responding at all to anti-VEGF, and this has other criteria like systemic factors, or sometimes they are VEGF non-responder. Should we continue injecting this patient? This is a dilemma, because the patient will lose faith. If you inject him 3 times and his vision is getting worse and central thickness is getting worse, I don't think you would be honest to continue the same anti-VEGF. Maybe these patients are VEGF resistant, we don't know, but keep injecting, I don't think so. Switching to another anti-VEGF, some people switch directly to steroids in these cases. Let's discuss this. Anti-VEGF therapy worthwhile even when diabetic macular edema persists. This is a writer issue came in on the internet, and we did a survey suggesting that some doctors treat with just few injections, 1 or 2, and then there is no response, they rapidly shift to another anti-VEGF. And this is not the case, because CR network received at least 6 injections to say that this patient are persistent diabetic macular edema. So my advice, don't give up in the first, second, or third injection sometimes, because at the 6th injection, you might get a result. And the implication that continued treatment of anti-VEGF beyond just 3 injections still may have an advantage. So don't give up rapidly unless you see that macular edema is progressing and the vision is deteriorating. But if you get any benefit, even moderate or poor responder, you might get response after 6 injections. And here's a patient at poor response after 3 loading dose. And we can see that the central subfield thickness is almost the same or even increasing to 20 microns, but we can consider this almost the same. But after 6 injections, we started to get a good response. So we shouldn't give up early on any anti-VEGF, because we all know that anti-VEGF is the standard of care in these cases. This from the trials, RISE and RISE, delayed responder. In RISE and RISE, 9 to 10% of ranibizumab treated eyes were delayed responder after 3 injections, and they responded after that. So delayed responder achieved a reduction of central retinal thickness after 24 months, close to the immediate responder. So it doesn't mean that the delayed responder will not respond anymore. On the contrary, at the end of the study, they found that the delayed responder, but they said responder, not non-responder. Also in protocol I, patient with diabetic macular edema who had a poor visual initial response to treatment may achieve clinically significant visual gain with continued treatment. So it means poor initial response. It doesn't mean that this patient will not respond anymore. Some of the trials went in switching from one anti-VEGF to another, and this is a prospective randomized comparative trial, ranibizumab and bevacizumab resistant diabetic macular edema. This switch from bevacizumab to ranibizumab after the resistant. And in conclusion, after conversion to ranibizumab in eyes with persistent diabetic macular edema, refractory to bevacizumab, significant functional and anatomical. So they improved in the vision and in the anatomical. Also conversion to aflibercept after prior anti-VEGF therapy of persistent diabetic macular edema. In this study, they shifted from one anti-VEGF to another. So they shifted from bevacizumab and ranibizumab to aflibercept. And they found out that conversion to aflibercept for resistant diabetic macular edema resulted in significant, look at this, anatomical improvement. But while trends towards improved visual acuity and reduction in intraocular pressure were observed, these were not statistically significant. Sometimes you get very good anatomical, mild visual improvement, but it's not statistically significant. So it means sometimes the anatomical is not correlated with the visual outcome, and we all see this in our practice. So again, conversion to aflibercept for diabetic macular edema, unresponsive to ranibizumab or bevacizumab, and at the results down there, I use diabetic macular edema, unresponsive to multiple injection of Avastin and Lucentis, demonstrated anatomical and visual improvement. Sometimes they say anatomical, sometimes they say visual, but they never say in some of the literature how much vision is improved. Is it statistically significant or not? Again, analysis saying that 3 monthly intravitreal anti-aflibercept injection had benefit in nearly 2/3 of cases with diabetic macular edema. 2/3. How about the last 1/3? Again, there is resistance to the switched anti-VEGF. Let's go to clinical practice. Sometimes we get non-responder, like this patient had shifted from Avastin to Lucentis, and after the first injection from shift, the improvement was marvelous. So sometimes we find a marvelous response after switching from one anti-VEGF to another. Here's significant shifting from Avastin to Lucentis. Again, after repeated up to 6 injections of Avastin, and I shifted to Lucentis, and 1 or 2 injections sometimes can get the answer, because sometimes there is no response to this anti-VEGF, so it is not harmful to switch, but you should not switch that early. But here is a non-responder. Look at this. Central subfield thickness is almost 600, and you have 3 loading dose and 3 more injection, and there is no response. Even less than 10% response. Look at this. It is cystoid edema, non-responding, central subfield thickness is almost the same, from 524 to 544. So it means that there's minimal increase in the central field thickness, but again, there is no response. There is no way to continue injecting anti-VEGF in this. So should I switch to another anti-VEGF? I did switch to another anti-VEGF, but I gave a one injection, and look at this. Central field thickness came to 642. So it's progressive. So it sounds that this patient is not a VEGF dependent. It sounds like this patient will not respond to any anti-VEGF, because once you inject, sometimes you inject 3 more injections after you switch, but the first injection, if you find that the vision is dropped and the central subfield thickness is increasing, you should think of steroids, because steroids have a role in these cases, the chronicity, the hyperreflective foci, and we have a sign of epiretinal membrane, though there is no much traction, but switching to intravitreal steroids, central subfield thickness went down to 40%. Would the vision improve? No, the vision did not improve much. Much anatomical, but not functional. But again, anatomical sometimes is preventing for further visual deterioration, because if you leave this patient, you might develop a partial thickness macular hole, you might develop a full thickness macular hole, so you are harming the patient. So the question is sometimes when to switch to steroids. In cases with VEGF non-responder and you shifted to another anti-VEGF without any response. And pseudophakic patient, why don't we try steroids sometimes in pseudophakic patient? Because still have the ability to switch to steroids directly. Or there is any contraindication to anti-VEGF. I have a patient who had 3 anti-VEGF injection. After the 3rd one, he had heart attack. I don't blame the anti-VEGF, but he came to me after the 3rd injection with a stroke, and he said, I need to be injected in 2 weeks. I said, there is no way, I have to shift to steroids. And sometimes diabetic macular edema with epiretinal membrane, because we all know that anti-VEGF with a cellular membrane can increase the traction and end up with a macular hole. So here is one more patient, persistent cystoid macular edema in spite of switching. You can see after 3 anti-VEGF, switching to another anti-VEGF, the edema is increasing, the subretinal fluid is accumulating, and we can see how much hyperreflective foci in there. So this is a chronic cystoid macular edema with inflammatory mediators, and 1 injection of steroids had a 50% reduction and regain of vision. So it means that steroids still have a role in this. This is the patient, one-eyed patient who had diffuse macular edema, and look at this, significant traction with epiretinal membrane, and the patient cannot do surgery because he's systemic condition. He refused completely to do surgery. It is hazardous, and the only way is to inject him with the steroid to keep the vision at least not deteriorating. So this is intravitreal steroid injection, which stabilizes the condition. The vision will not improve much, but at least we can control the condition. So effect of adding dexamethasone to continue ranibizumab treatment patient, protocol U, they said that objective is to compare continued intravitreal or to add dexamethasone, and they found out that although the use is more likely to reduce the retinal thickness and increase intraocular pressure, in addition to intravitreal dexamethasone implant, to continued ranibizumab therapy does not improve visual acuity. So sometimes, as I said, anatomical, but not visual, but at least keep the vision stable. So my take-home message is definition of responder, non-responder from poor or inadequate responder is important in the management of diabetic macular edema. And anti-VEGF is still the drug of choice in initial treatment of diabetic macular edema, and switching from one anti-VEGF to another is the second line of treatment, at least in my clinical practice. And steroids still has a role in diabetic macular edema, particularly in VEGF resistant, in pseudophakia, if there is any contraindication to anti-VEGF, like the patient who is getting a recent stroke, and steroid treatment is associated with significant risk of cataract progression and glaucoma. So treat the patient and prepare the patient for the complication and consult the patient. And I think this will be helpful for all of us. Thank you so much for your listening.
Thank you very much, Dr. Majdi. It's excellent presentation as usual.
Thank you.
There is one question before we move to a next. If there is any question from the panel here before, Dr. Patricio, Dr. Chawla, Dr. Kridhar, anyone?
I would like to ask Dr. Magdi if he feels in India we've had a shift to use of more of dexamethasone implant in the COVID era, because some elderly patients, diabetics, want to reduce their visits to the hospital for diabetic macular edema injections. Is there such a trend in your part of the world?
Yes, it's possible, but in my clinical practice, I prefer to shift to another anti-VEGF, and you all know that some anti-VEGF can maintain to 12 weeks, 16 weeks. So I never switch to steroid unless I am, I cannot switch to another anti-VEGF. But if I can switch to another anti-VEGF, long-acting, it will sustain for 12 or 16 weeks. But again, it is ideal to switch to another steroids like intravitreal dexamethasone implant, but in our country it's a bit expensive than the anti-VEGF, and it does not stay for 6 months. As you know, it's 3 to 4 months. So again, it is, yes, 3 months, maximum 4 months, and still aflibercept can do the same in my practice.
Thank
you. Yeah, Dr. Patricia, please go ahead.
I just wanted to ask you, mainly for the audience, after how many Osurdex and bouncing back edema you start thinking of using fluocinolone implant?
I never used fluocinolone. We don't have it in Egypt, by the way.
Well, then Dr. Alhambri, that I know he has a good experience with fluocinolone, maybe you can answer the question.
Can you just repeat what is the question? Sorry, Dr. Patricia.
Yeah, you switch from anti-VEGF from one to the next anti-VEGF, then it doesn't work, you switch to dexamethasone. But yeah, you know that some patients, after 3-4 months, the diabetic macular edema comes back after Osurdex.
Yes.
So and you re-inject Osurdex and the edema comes back. So after how many injections of Osurdex with the edema coming back, you start thinking of using fluocinolone?
Actually, let me say in this way. It is not depending how many injection you are give us of Ozurdex. Sometimes only maybe one injection, but you find that the patient is not able to come, and better for him to have a visit us only in a long period of times. So I give the Iluvien. Sometimes even for me, even though I know in our area, dexamethasone should be given before Iluvien, but I have some patient I didn't start even with dexamethasone. I go directly to Iluvien. So it's a patient per patient itself. There is no special things that I can measure or say that's because of no responding. But sometimes I feel even in a chronic, and if the response in for the dexamethasone not that much what I was anticipating, if we are having a very high diabetic macular edema, 700, 800 and something like that, and you give Ozurdex, yeah, it is improving, but not that much. So I do prefer to go for Iluvien, even though sometimes I have a top-up of dexamethasone on top of Iluvien. Iluvien, you can say it's maintained, but sometimes if there is no good control of blood sugar, it's not the patient is, sometimes there will be a flare up, like I can say in the macular edema, and if it is high, then I use usually a dexamethasone on top of Iluvien, and sometimes even anti-VEGF, I can use as a top up on top of Iluvien. I think if that's clear, Mike, answer your question, Dr. Patricia.
Yeah, it's clear enough. I would also include probably the vitrectomy size.
Yeah, there is many indications. I'm talking just in case, but
yeah,
sometimes we are using, because the indication of Iluvien is similar to the indication of dexamethasone almost. Yes.
Thank you.
But I have a question to Dr. Majdi, even though we are exceeding the time, but I don't mind this one because Dr. Majdi, you have to.
No, you are the moderator. You can exceed the time anytime.
No, but because we get to benefit from you. You are the boss or the king of treating a macular, medical retina in general and diabetic macular edema. Do you still believe that there is a difference from one anti-VEGF from another one, or almost they are similar? I mean, now the trend is not to shift from one anti-VEGF to another one. You can go directly either from this one or directly to the steroid.
No, I
even though by the way, but we are not using Avastin. We are talking about ranibizumab and aflibercept.
I still think that some of the patients would get benefit from switching from one anti-VEGF to another, even from aflibercept to ranibizumab sometimes. I still think that anti-VEGF is still working.
So you are thinking you start with aflibercept, sometimes you shift back to the ranibizumab.
You can do that. Sometimes when you fed up with aflibercept, you switch to Lucentis. I get some results. I do that, but I don't hurry to shift to steroids. But I said, switching from one anti-VEGF to another, sometimes you can get benefit.
Thank you very much. Any comment, Dr. Patricio? Dr. Patricio, if you want to. Hello.
No, I was just saying that the incidence of glaucoma with dexamethasone is very low. I don't think that should be a cause for any concern.
Yeah, this is my belief. I think it's, yeah, if you are thinking about the glaucoma, or if you have to want to say it's properly, there is an increased intraocular pressure, which is represent about 20% or 19%. A glaucoma in real practice is less than 2-3%, not more. Before they are mentioning 5%, but now how long we are using, I didn't face any case to need to do a surgical intervention glaucoma surgery. Or you are treating either by 1 or 2, and I didn't find even 3 drugs to use to treat the glaucoma. Especially if we are using dexamethasone, it's only it's not at all times and causing a glaucoma. Only it can happen in the high period of times after 1 month or 2 months. Then after that is declining again. This is my practice. I don't know if any other one has any comment. Dr. Majdi?
How about cataract? I'm afraid also of cataract. And second thing, you don't
cataract, it happens, most of the time after 18 months, most of the times,
Yes.
But usually most of our patients, they are in old age, and they are almost times they are having some sort of cataract. So we are avoiding any patient that they are clear lens. Yeah, that's sure. But if some patient is having already a cataract, and sooner or later you are going to do this cataract. So even sometimes I keep to give the steroid during the surgery itself.
That's a good option. Yeah, that's a good option. Removing the cataract and giving intravitreal dexamethasone implant.
Okay, we will not finish with Dr. Majdi because all the times he is initiating our mind to ask a lot of questions. Dr. Patricio, if you want to introduce, and Dr. Patricio are with me. So our second speakers, you have the agenda with you?
No, I don't. Go ahead.
Okay, so I will, in behalf of you, I will introduce our guest speakers, and we are happy that he is with us and accepting our invitation. Dr. Giridhar, he will talk about recurrent chronic CSR.
Thank you.
Can you share your screen, please? And we need to see you also. The audience, they want to see you while you are presenting. It will be great if you can open the camera, please. Hello.
Yeah, can you see the screen now? Can you see my presentation?
Yes, please. Yeah, you can go ahead.
Yeah, thank you.
Can you open the mic? The camera, so that we can see you at the same time?
I'm having a difficulty with my camera. So
okay.
I will do something. Immediately after my talk, I will switch on the camera.
Okay, go ahead, please.
Yeah, I'm sorry for that.
Not a problem.
Yeah, so thanks a lot for giving me an opportunity to participate in this program. And I'll be talking on recurrent and chronic central serous retinopathy, and I'll also give some of our experiences in the management of this condition. So I have no disclosures, and these are some of the very interesting recent publications in central serous choroidal retinopathy. And those of you who are really interested, they can read this particular article, which has come a couple of years ago, which gives us a very good concise information on the management, current management of central serous chorioretinopathy. So my presentation objectives, basically, I'll just define.
Can you go to full screen, please?
Yeah, 1 minute. Yeah, I will define, and then a few words on the diagnosis and the differential diagnosis, the management options, case examples, review of literature, and what is my approach in the management of chronic central serous retinopathy and recurrent central serous chorioretinopathy. So how do I classify CSCR? Actually, I classify CSCR into acute, chronic, and recurrent. There is a lot of overlap as far as chronic and recurrent disease is concerned, because many patients with recurrent disease are probably chronic, because we really do not know whether many patients with acute central serous chorioretinopathy have a complete recovery with a dry macula, and when they come with recurrent disease, whether it's a recurrent disease or a persistent disease that is presenting as a recurrent or a chronic disease. So this is one of the challenges as far as the diagnosis of central serous chorioretinopathy is concerned. And therefore, the interpretation of multimodal imaging becomes very, very important, because multimodal imaging today gives us enough information to tell us whether it's an acute disease or whether it's a chronic disease. Therefore, if you look at the OCT here, this is a case of an acute central serous chorioretinopathy where you have a very clear sub-retinal fluid here. But in this particular slide, you can see here there are multiple hyperreflective dots here within the serous macular detachment that tells us this little bit of a chronic disease, and the presence of cystoid changes definitely is an indication that it's a chronic disease. Therefore, looking at the OCT has to be examined very carefully to tell us whether it's an acute or a chronic disease. Also, fundus autofluorescence is very useful. If you look at the fundus autofluorescence, this is a case of an acute central serous chorioretinopathy where we have this hypoautofluorescence. Basically, the fluid is causing the hypoautofluorescence. But then in chronic central serous chorioretinopathy, you get this granular areas of hypoautofluorescence or this tract formation, which are all indications of chronic disease. It's very important as far as the differential diagnosis is concerned. Most cases, of course, are very classic cases, but in any patient who is presenting with recurrent serous macular detachment above the age of 50 years, we should look at the OCT very, very carefully. Therefore, here we see the serous macular detachment, but if you see very carefully, you see this irregular, flat, irregular, or what we call as the double layered sign. And if you do the OCT very carefully, you need to see the OCT at various sections in the macula. And if you see here, you see this particular elevation here. And this is not a case of a central serous chorioretinopathy, but it's a type of a type 1 choroidal neovascular membrane or a pachychoroid neovasculopathy. Therefore, in any patient above the age of 50 years who's presenting with recurrent serous macular detachment, we should keep this in mind. And if you have the facility of an OCTA, probably this is a very good indication for an OCTA to look for this neovascular network, which may be there between the Bruch's membrane and the retinal pigment epithelium. Therefore, how do I manage my patient with chronic CSCR? We need to look for risk factors. This is very important. We need to do a very detailed history. History is very important. And we need to look out for any drugs that the patient is on for the cause of the chronic central serous retinopathy. Lifestyle modification is very important in chronic CSCR. There are a lot of studies which have shown that there are various risk factors for recurrent and chronic central serous chorioretinopathy. One of the causes is supposed to be sleep apnea. It's also obesity is supposed to be a cause. Mental stress is a cause for a recurrent central serous chorioretinopathy. It's also been seen that people who work continuously in night shifts are candidates for recurrent CSCR. Therefore, lifestyle modification may help in the management of some of these patients. Fundus fluorescein angiography and ICGA in specific cases are very important. Extrafoveal leak focal laser. We do a lot of low fluence or half fluence photodynamic therapy, which I'll explain later. And in patients of an absence of leak, we can observe or certain oral medications or resort to low fluence photodynamic therapy. So I will show you a few cases here. This is my first case. This is a patient whom we have a follow-up of nearly about 10 years now. This patient presented with a good visual acuity initially. This is the fundus photograph to show you bilateral serous macular detachment. And if you look at the OCT, the patient has got bilateral disease, bilateral serous macular detachment, a bilateral central serous chorioretinopathy. Fundus fluorescein angiography shows you a leak which is more or less subfoveal in the right eye and an extrafoveal in the left eye. Since the patient did not respond to any conservative management, finally the patient received focal laser photocoagulation to the left eye. The right eye, of course, was managed conservatively, considering the subfoveal leak in this particular situation. So patient did improve. You can see the left eye has shown decrease in the subretinal fluid. The right eye had a spontaneous improvement over a period of time. But this patient was lost for follow-up and came back in 2014. And at that point of time, the patient had active disease in both the eyes. You can see here, the eye, which was the right eye, which had a spontaneous resolution, has got a large serous macular detachment, and the eye where the focal laser was given was also having a large serous macular detachment. Over a period of 1.5 years, the patient had 3 fluorescein angiograms, and the patient continued to have active leaks in both the eyes. The patient received 2 or 3 sittings of focal laser photocoagulation because the patient was symptomatic and did not respond to conservative management. Patient also underwent an ICG angiography at that period of time. We did not have an OCTA at that period of time, just to look also for any type 1 neovascular network, and also to identify the dilated choroidal vessels, which is just seen in patients with chronic central serous chorioretinopathy. Therefore, since the patient, in spite of 3 sittings of focal laser photocoagulation over a period of 1.5 to 2 years, came back with recurrent disease, you can see here that is not only subretinal fluid, but then these hyperreflective areas, which is an indicator of a chronic disease. And finally, the patient had a half-fluence photodynamic therapy in both the eyes. Following photodynamic therapy, you can see here there is complete resolution of the subretinal fluid, and the patient has been under a follow-up for nearly 3 years after PDT, and there has been no recurrence at all. This is the fundus autofluorescence for you during the acute phase and during the chronic phase, just to show you the areas of focal areas of increased autofluorescence, both in the left eye and also in the right eye. Therefore, after post-reduced fluidity, I have a picture here at 1.5 years, but we have this patient even now under a follow-up, and even after about 3 years of follow-up, there has not been a recurrence after a low-fluence PDT. We have performed PDT in over 120 eyes with chronic central serous chorioretinopathy with good response. The most important take-home message is the incidence of recurrence after PDT is very low, and we also seen the choroidal thickness does decrease following photodynamic therapy. So this is the first case. This is the second case which I'd like to show you. Therefore, the first case actually was a case of a recurrent chronic central serous retinopathy, and also at a certain extent a chronic central serous chorioretinopathy. This is a second patient I would like to show you. This is a patient with a defective vision in the right eye, and I mean basically the defective vision in the left eye. You can see here the patient has got a serous macular detachment here, and the patient had a subfoveal leak. Now, subfoveal leak is really a challenge. Some of the patients with chronic central serous chorioretinopathy have a subfoveal leak. This can be either treated with a micropulse laser or photodynamic therapy. This patient underwent photodynamic therapy here with a 2-year follow-up. There was complete resolution of the serous macular detachment, and there has not been a recurrence. Therefore, in our practice, actually, the role of PDT in our practice is a non-resolving central serous chorioretinopathy of more than 6 months with a subfoveal leak, in chronic central serous chorioretinopathy resistant to conventional forms of treatment, and in recurrent central serous chorioretinopathy. Therefore, these are the 3 situations where we use half-fluence photodynamic therapy. This is my last case. This is a 52-year-old patient who has been under my treatment, under our treatment since 2011. The right eye had good vision, the left eye had poor vision. He is also having associated diabetes, mellitus. Now, if you look at the right eye, it's got RP atrophy. The left eye has got a serous macular detachment. Now, this is a classic case of what we call as a diffuse retinal pigment epithelial disease or chronic central serous chorioretinopathy. This is usually bilateral in most patients. This is usually seen in patients about between the age of about 40 to 45 years. We really do not know why some patients with CSC are present in this manner, whether there is some genetic predisposition. So the right eye was quite bad. The left eye, of course, had a serous macular detachment, and I was more interested mainly in treating the left eye. The left eye actually patient was managed conservatively. Initially, there's the ICT angiography just to show you focal areas of choroidal vascular dilatation and choroidal hypercyanescence. And this is the fluorescein angiography. The fluorescein angiography was done on multiple occasions and did not show any leak in the left eye in spite of active disease. So this patient also underwent an OCTA and there was no actually neovascular network. So over a period of 5 years, he has been under follow-up. You can see here, there's a waxing and waning of the disease. 2015, July, there is no fluid. Again, in November, there is some fluid. Again, a couple of months later, there is no fluid. Therefore, a waxing and waning phenomenon, no leak in fluorescein angiography. Patient was managed conservatively for a couple of years. However, finally, actually, since he was developing a chronic disease with chronic central serous choroidopathy, I was reluctant to do photodynamic therapy in this particular case because already he had got RPE disease. In patients with RPE disease, the photodynamic therapy can worsen RPE damage and photoreceptor damage and worsen visual acuity. And considering that this patient is practically one-eyed, I started this patient on EPTUS. With EPTUS, of course, there is slight improvement in the subretinal fluid. But then actually in our experience, really Epleron in long term does not really have a very good effect in management of chronic central serous retinopathy. Therefore, see Epleron, what we do normally do is we start them on 25 milligram per day and then shift them later to 50 milligram per day. But then we look at the possibility of hyperkalemia and we need to monitor these patients very carefully and we need to educate these patients that they need to come for very, very regular follow-up. The VICE study, which compared Epleron with the, which looked into the treatment of chronic central serous retinopathy with Epleron, showed that it was not superior to placebo for improving BCVA in people with chronic central serous retinopathy after 12 months. Therefore, do I use oral medications for central serous choroidopathy? I personally feel that the role of mineralocorticoid antagonists is unpredictable and debatable. It can possibly be tried in eyes with persistent subretinal fluid and absence of any leak in fundus fluorescein angiography. It's important to remember that delay in treatment can lead to photoreceptor and RPE fallout and permanent visual loss. The other modality of treatment is the subthreshold micropulse yellow laser photocoagulation or the subthreshold micropulse diode laser photocoagulation. We have a limited experience with this particular technique. We have been using it, but then again, the results are unpredictable. And if you look into the literature, about 50 to 60% of patients who have been treated with micropulse have shown favorable results. This is a very important place trial which compared half dose PDT with a subthreshold micropulse laser. And it clearly showed that PDT was far superior to a micropulse laser in the management of chronic central serous choroidopathy. Therefore, my take-home messages as far as the diagnosis and management of recurrent CSCR and chronic CSCR is concerned is, one is the importance of multimodal imaging to diagnose and interpret chronic central serous choroidopathy. Detailed history is important. We need to look for risk factors and modifiable lifestyle factors can be given a lot of importance in the management of central serous choroidopathy. Patients need a very close follow-up. OCT is an important tool for follow-up, and it's very important that in patients who are above the age of 50 years and in chronic disease, we need to approach these patients differently, and the role of OCTA and ICT angiography in this group of patients has to be overemphasized. Thank you.
Thank you very much, Dr. Giridhar, for this very interesting presentation and excellent, comprehensive. Yeah. You have give us a lot of information really about CSR. Maybe there is some question in mind of our colleagues here. Dr. Patricio, if you have any question to Dr. Giridhar.
Yeah, about the experience on repeated PDT. I have done many PDTs back in the 98, 99, 2000. But what I find for patients and repeating PDT for chronic CSCR is that they can end up with a decreased visual acuity, retinal thinning, and choroidal thinning. What's your experience? Because I'm sure you have some of these cases.
We have actually, we have never repeated PDT in CSCR. I mean, in all our patients, we are given only one cycle of half-fluence PDT, and I'm also very reluctant to repeat PDT in patients with CSCR. But the incidence of recurrence after PDT is quite low. It's only probably about 3 to 5% over a period of 2 to 3 years. Therefore, there are very few patients who are coming with recurrence. If they come with a recurrence, then we manage conservatively or with oral medication. So I fully agree with you that I would not advise to repeat PDT in patients with central serous chorea.
Okay.
Thank you. Any other question? Yeah, go ahead, Dr. Batisha.
Any experience in using melatonin for these cases?
No, no. What about you? You have used?
I'm trying with melatonin, but I have a very short experience, and I cannot tell you that if it is different from placebo for the time being. I've been using it for the last 3-4 months.
Yeah.
Dr. Majdi, if you have any comment or question?
Yes. Would you consider, I mean, you said chronic CSC. Would you consider giving eplerenone in an acute phase? I mean, you shouldn't wait for the patient to be chronic. I use that sometimes in young patients who demand the vision, and it gets nice results. I mean, I use it in the acute. I don't wait for the CSC to be chronic. I use it from the beginning, and I have more than 4 or 5 cases who responded very good in the acute phase. What
Yeah, I mean, I agree with you, Maggie, but the problem in acute CSCR is many patients have a natural course which is favorable.
Yes.
That's where the problem is. So when we give these drugs, we really do not know whether the disease is going because of the drug, or is it a natural course of the disease that is favorable. So in an acute patient, say, who comes with 1 week history or 1 month history, usually I talk to them and just ask them to come after about 1.5 to 2 months. I may give a non-steroidal ketorolac eye drops or something like that to the patient just as a placebo, and call the patient after 1.5 to 2 months for a checkup.
Okay.
Okay, thank you very much. Is there any question, more question to Dr. Gridhar about his CSR management? I have one question. This is so many people in their mind asking, is there any role for anti-VEGF in these cases? I mean, in a chronic type of...
That's a good question, sir. I think anti-VEGF, there were some reports that anti-VEGF is effective in central serous choroidal retinopathy. But I feel that those are the cases which probably were type 1 choroidal neovascular membrane. They were not classic central serous choroidal retinopathy. Therefore, in classic central serous choroidal retinopathy, I don't think there is any role for anti-VEGF action. Because our knowledge and our understanding has improved so much over the last 3 to 5 years. So basically, now we know that those are the cases with type 1 neovascular network.
Thank you very much. Yeah.
Can I ask a question?
Yes, you are there. Okay, I didn't see because you are mute and you are hiding your face, so I don't know that you are there or not.
Dr. Giridhar, excellent talk. Very comprehensive and up to date. Just one quick one.
Yes.
We do see a lot of patients of CSC who are on steroids for the systemic reasons. And
Yes,
even after discussing with the internist and the physician who's treating, we are not able to reduce the dose, like patients who are on SLE or things like that. How do you approach patients like this? Yes, we want to reduce the dose, but if it's not possible, would you consider PDT as an option for these patients?
Yeah. You can consider PDT as an option in these sort of situations.
Early in the disease?
Pardon?
Early in the disease, or would you want to wait?
No, you can wait. You can wait about 6 months. What I would suggest is in these sort of cases, you can try 1 cycle of focal laser if there is a leak and see what happens. And subsequently, we can consider PDT in case it is persistent. Recently, actually, I did in a patient like this about 1 year back. There was a patient like this with bilateral disease. I mean, the treating physician said he cannot stop the steroid. So finally, I did PDT, and after PDT, he's doing quite well. So it does work. I'm quite reluctant to do PDT because I thought even that may fail, but surprisingly, PDT works. So that's an option that we can consider in these sort of situations.
Does it reduce recurrence? Because they have to still be on steroids.
No, it reduces recurrence. In spite of the fact that he is on steroids, it reduces recurrence.
Okay. Thank you. Thank you very much.
Thank you very much, Dr. Gridhar, for this presentation, and thanks for all comments from the panelists and questions. We will go now for our guest speakers, Dr. Shobit Chawla, and we are proud that and honored to be with us. And he will present about post-cataract cyst macular edema.
Thank you very much, Dr. Amri. Thanks to you and your society for inviting deliberation. So, post-cataract cystoid macular edema was initially reported way back in 1953 and 1966. It is a pathological response of the retina consisting of fluid accumulation in the outer plexiform and inner nuclear layer of the macula that results in the formation of cystic spaces. It's cystoid, not cystic, since these spaces are not lined by any epithelial cells. A moderate increase in macular thickness does occur between the first and sixth week after cataract surgery and has no significant correlation between that and the visual acuity. The pathogenesis is necessarily vitreomacular traction and inflammation, incomplete posterior vitreous detachment, anterior to posterior traction on the macula, and development of cystoid macular edema. With inflammation, there can be ischemia and inflammation, intravitreal cytokine release, increased permeability of retinal vascular endothelium, and development of cystoid. The pathway, this is the same pathway which you would see when topical prostaglandin is being used. There is an initial intracellular fluid accumulation in Mueller cells, which rupture to form cystoid spaces. The post-operative risk factors are, it is more after posterior capsular rupture. Other procedures like penetrating keratoplasty, buckling, PRP, and VR surgery rebound edema after epiretinal membrane surgery. High-risk cases are history of cystoid macular edema in the fellow eye, ruptured PCV, complicated prolonged surgery, uveitis, diabetes, venous occlusion, ARMD, and topical prostaglandin use. In various modalities of cataract extraction, we find that those modalities, the more modern modalities like phacoemulsification and femtosecond assisted cataract surgery show significant decreased incidence because maybe the time taken is less and there is less disruption of the blood retinal barrier. In anterior chamber IOLs, the incidence is higher, and many times when we see that the AC IOL has been inverted and not put correctly and is rubbing on the iris. Iris fixated IOLs, it's also higher. In eyes which are predisposed with AMD, there can be a higher incidence, and I like to do an ICG in these patients if it's there to exclude any element of polyps or branching vascular networks, at least in our scenario in India. So the incidence is low in uneventful cataract surgery, more in males. In diabetic retinopathy, in the presence of diabetic retinopathy, it is definitely higher. Diabetes mellitus, even in the absence of DR, has been shown to almost double pseudophakic CME incidence rates. The incidence of CME post-cataract has also been reported with eyes with DR. And we all know the clinical features, which are decreased visual acuity, metamorphopsia, micropsia, and central scotoma, can be very easily diagnosed on a good 90D examination. And that's something which I take my fellows to do in all cases of macula, rather than jumping onto OCT and fluorescein. Small intraretinal and intracystic hemorrhages may be seen. There may be microaneurysms. Post-cataract surgery, vitreous cells and flare and ruptured anterior hyaloid face. OCT is, of course, diagnostic and can be seen. It also is important visualizing any vitreoretinal interface to see role of vitreous traction. Fundus fluorescein angiography is definitive, and we do it in quite a few cases, especially if they are non-responsive. We may not do it in the first visit, where an OCT may suffice. And you see, rupture of the cyst may lead to lamellar macular hole, and prolonged CME may induce atrophy of macular receptors. So it's important to treat it early and recognize it early if it is persistent. And post-op visual visual acuity is not always the recovery is not only the only marker, but contrast sensitivity has become an important factor. The American Academy of Ophthalmology has tried various modalities, and there is no evidence that benefits of NSAID therapy could not be obtained with equivalent of a corticosteroid. And both in conjunction have not been normally advocated. We normally like to start our patients on NSAID and most commonly Nepafinac, because that has a good, it builds up with chronic use. Nepafinac over 2 weeks, 3 weeks use builds up a depot in the sclera, as it is well known, and has a sustained effect also. Corticosteroids can also be used, and because they suppress macrophage activity, decrease intracellular and intercellular edema, and decrease lymphokine activity. So topical drops, posterior or subtenon injections, intravitreal implants, and at various rarely a pulse therapy or oral may be needed, but no, normally it's good enough to use topical and or an intravitreal implants. Subtenon injections offer an alternative to deliver relatively high doses of corticosteroids to the eye with lower risk of systemic complication, but you can have persistent intraocular pressure and intraocular penetration also side effects. Carbonic anhydrase inhibitors have also been used. Laser vitreolysis, where there are vitreous tags in the anterior chamber or going into the wound. Pars plana vitrectomy for active vitreomacular traction. So this is a case of uneventful cataract surgery, which developed cystoid macular edema, was symptomatic, and just topical steroid and Nepafinac resolved it in a brief period. This is just a 2-week follow-up. Then IOL implant in a sulcus treated with topical steroid and Nepafinac again, showed good resolution, again a duration of about 8 weeks here. Uveitis, uneventful cataract surgery using a pupil expanding device. The patient had severe cystoid macular edema. 2 months after, needed 2 months of topical steroid and Nepafinac therapy. It can be recalcitrant at times, and then I personally like to use the dexamethasone implant. As you can see here, the central macular thickness has not gone down that much, but the visual acuity has improved after dexamethasone implant. So persistent edema with post-op decreased visual acuity, I like to do an OCT. If needed, FFA. If underlying AMD is there, I might do an ICG also. Institute therapy, topical steroids and NSAIDs for 6 weeks. Repeat visual acuity, and if I have persistent, I would like to look at the cause and treat it. Definitive management of coexistent entity. If just persistent CME is there, response to treatment continue 4 or 6 weeks. Persistent non-responsive, consider dexamethasone implant. Thank you very much for your kind attention, and thank you for the opportunity to present in your society.
Thank you very much, Dr. Shubhit Chawla, for this interesting and excellent comprehensive talk about the cystoid macular edema. Maybe there is a lot of questions about this topic because there is a lot of things to talk about. I will start with Patricio. Go ahead.
Thank you. Yeah, Dr. Chawla. You do the perfect cataract in a person, and after 4 or 6 weeks develops this Irvine-Gass syndrome. Are you planning the next eye with some different medication pre-op or immediately post-op? maybe intraventricular.
I will definitely start the patient on pre-op Nepafinac or an NSAID a week before, and I'll make sure he's not using on any topical prostaglandin. If that is so, I will discontinue it for at least 2 weeks before I take up this eye, because the washout of topical prostaglandin takes up to 2 weeks if the patient is on anti-glaucoma therapy with topical prostaglandin analogs.
Thank you.
Any other question, Dr. Patricio?
No, it's just more a semantic question. In a diabetic patient, you
Yes.
operate on a cataract and develops macular edema after, again, 1 month, 6 weeks. How can you differentiate if it is diabetic macular edema or if it is an Irvine gas syndrome, if the cataract went uneventful?
I think you should just give a trial of, definitely do a fluorescein angiography, look for the microaneurysms or intra-retinal microvascular abnormalities, and if you feel that he's not responding, go ahead with anti-VEGF therapy. In fact, if we find that there is a little indication, we many times of such an incidence and patient has some features, we do anti-VEGF therapy prior to taking him up for cataract surgery, or combine the same with an intravitreal dexamethasone implant or anti-VEGF. I would like to ask, if there is time, I would like to ask Dr. Giridhar's opinion as to cataract surgery along with AMD in our Indian scenario, and whether you see it in the Middle East also. Many patients show an increase, and these are the patients we many times end up doing an ICGM to rule out any other feature, especially if they have RP abnormalities and there is an increase in cystoid macular edema, bumpy RP, increase in cystoid macular edema post-cataract. I would like to ask Dr. Giridhar how he feels these cases should be managed, both investigation-wise and therapy-wise.
Number one is, that's a very important question. I mean, that is coexisting retinal disease. So number one is, what I tell my colleagues is that when we advise cataract surgery in these situations, I think we should make sure that really the cataract surgery is necessary.
Yeah.
Because one of the things is, you know, in patients with who are under treatment for wet AMD or macular disease who develop a cataract, I mean, a cataract surgeon, you know, the moment he sees a cataract, he is keen on removing the cataract. But unfortunately, these diseases behave in a very different way after cataract surgery. So that's number one, is we have to make sure that the cataract surgery is really necessary. And basically, I mean, at least we need to counsel these patients that after cataract surgery, they may need more intensive treatment than what they normally do. So as far as diabetic macular edema is concerned, I agree with you that I give Osudex in such situations because that works on a longer period of time. And as far as the AMD is concerned, basically I may go for a better drug. A better drug. I mean, like...
You mean, doctor, by better drugs?
Yeah.
What is the better drugs you mean?
Like aflibercept. I mean, I may be using aflibercept because in India now we have a biosimilar also of ranibizumab, which is available, which is used quite extensively. So I would prefer to go for aflibercept because that's got a longer period of action and it's more effective in most situations of these sort of situations, very effective. So go for aflibercept.
Thank you very much. We can, yes, doctor, you have any comment, Dr. Shawla?
No, I think it's a little late. I will ask that question in personal communication with Dr. Mauza. I was wanting to ask him, supposing it's a diabetic and there is, patient has had history of cystoid macular edema with poor baseline visual acuity. He's now stabilized and is now undergoing a cataract surgery. Would he like to combine it with aflibercept, or would he like to stick to ranibizumab? From Dr. Magdi Moza. You're muted.
Please. Muted. You are muted, Majdi.
Sorry, I'm opening. You said he already treated and he's stable. There is no macular edema preoperative, right?
Yeah, and we have now done. He had baseline poor visual acuity. We treated him with, as Dr. Giridhar has put, with a good anti-VEGF, and he has improved well, because in India we have a tendency of treating diabetics with poor baseline visual acuity with aflibercept nowadays, and he has improved well, stable, and now he's undergoing a cataract surgery. Should we prophylactically be giving him one injection with the surgery, or we should wait for the edema to recur?
No, I would inject during the surgery. I would not wait for the macular edema, especially if he already had the macular edema and responded. No, I would inject during surgery. I would do that.
That's just the thinking we have.
Okay, Dr. Majdi, you would prefer to inject anti-VEGF, or you will give here dexamethasone?
Yeah.
If the patient is diabetic macular edema and he was
he's a diabetic macular edema, as he mentioned.
Good responder to anti-VEGF, I would give anti-VEGF.
Okay. Dr. Batisho or Dr. Barasan, you have any comment or questions?
I think that both options are reasonable for a pseudo-phakic patients. As depends on the surgeon's preferences. I try to flatten the macula before going ahead for surgery, and yeah, I agree with Dr. Musa. At the time of surgery, you plan the surgery 1 month after the last injection and keep going. That's it.
Yes. For me, I do prefer to give, if the patient is okay and he doesn't have any problem, to give a steroid, and I will give a steroid. I mean dexamethasone, because I feel the patient, he will be during the 3 months coming after the cataract, it will tackles whatever it is. I mean, diabetic macular edema itself, or if he is going to develop Irving gas syndrome within this period of time. So you are covering both of them. This is my approach for this patient. If it's going to have no problem to do with giving steroid. I know you are not agree with me, Dr. Majdi, but this is what I'm doing. Okay.
I like you, but I don't agree with you. I like you. But
yeah, okay. This is the life. You will not agree with me anytime. Yes. This all the time you are against me. Yes, Prasan.
This question is to everyone actually. If you have a patient who's got a posterior capsular rent and who's had a scleral fixated IOL, and he develops cystoid macular edema. Now, the probable cause is the scleral fixated IOL. Would you go ahead and venture and remove the scleral fixated IOL, or how would you proceed in this patient?
I would first like to treat this patient medically.
Okay.
The condition goes on to a total non-responsive issue, then I might think counsel the patient about explantation. But initially, I would like to treat the patient with intra-retinal.
Yeah. I think I agree with Shobit. I think that's what I would do, because removing the IOL is a very drastic.
No, but eventually, if it's recurrent in nature, because the reason I'm asking this question is because I have a patient who have tried medically treating, giving him an injection. I avoided a dexamethasone because he's got an open posterior capsule. There's no posterior capsule. He just had a scleral fixated lens.
And why not do a vitrectomy in this patient? Just depress and do the vitrectomy, leaving alone the, just.
No, I think, yeah.
The cause is the iris getting shaft because of the posterior, because of the scleral fixated lens.
Just 6 months back, I removed one implant in a patient with chronic cystoid macular edema because the AC IOL had been put the other way around. So the vault was behind and the iris was chaffing away. So I had to remove it. There was no way. It had persisted for nearly 1.5 years. And I had already given him 3 dexamethasone. And he was now developing pressure elevations. His pressure has come down. His eye is quiet. He's a phakic in that eye. He has a good pseudophakia in the other eye. But he doesn't have the guts to implant again.
Okay. Thank you.
Thank you very much. Yes, Doctor. Yeah, last comment, please, Dr. Batisha.
I think that definitely you have to clear all vitreous strands, because a vitreous wick can actually produce Irvine gas syndrome. And then I don't think that the iris chafing is giving you any trouble at the macula. I have many cases with the old 911 silicone lens with iris chafing and not a single Irvine gas syndrome.
Yeah.
That's my take.
Okay, thank you very much. We
you.
are having actually the last talk, it will be by Dr. Majdi, but we have several questions, most of them to also, we need to finalize these questions. So, but I need only a very fast and short answer, please, if you don't mind, so that we can finish on time. There is a question, OCTA can differentiate between active, I think, choroidal neovascular membrane from fluid only around the scarred membrane. I think maybe this one was question maybe to Dr. Vishali, but anyone can give a short answer about this one.
What's the question?
Does, I mean, OCTA can differentiate between active choroidal neovascular membrane from fluid only around the scarred membrane?
Means if you have fluid only around a scarred membrane and an active CNV, can you differentiate with Octa or not?
Yeah, with OCTA.
OCT does not give you activity, gives you flow, but not activity. It's flow within the vessel wall. Activity
Okay, that's what we need.
doesn't mean anything for OCTA.
Thank you, Doctor. Okay. This is question to Dr. Megdi. This is from Dr. Sheikha Noura Al-Qasimi from Abu Dhabi. I think Dr. Megdi, you know her. She is in SKMC, dear colleagues. So thank you, Professor Majdi, for the great talks as usual. Why vitrectomy is the last favorable option to you? What is your opinion in DME with VMT? I think it's question very direct.
Yes, but I didn't say vitrectomy is the last option. Vitrectomy is the first option when you have a vitromacular traction, like anteroposterior traction or tangential traction. But some of the literature speaking about vitrectomy in persistent diabetic macular edema without vitromacular traction.
Okay.
But
why it is the last favorable here?
I didn't say it's the last favorable. I put it as a last option in treatment persistent diabetic macular edema without traction. But again, it has no role. I don't think it has a role even because we have a lot of cases who did vitrectomy and we still get recurrent diabetic macular edema. So in the era of Ozurdex and Iluvien, I don't think vitrectomy is a good option in cases of persistent diabetic macular edema, in spite of what is in the literature about oxygenation, removing the vitreous, separating the vitreous from the retina, because we have a patients with total PVD and they still get recurrent. Not like all days the vitreous has a role. No, we still have a patient with vitrectomy and they still have recurrence. So I put it in the last result because it is in the literature saying that vitrectomy could be an option in persistent diabetic macular edema if they already had antibiotics.
Thank you, Dr. Majdi. Okay. Does triamcinolone injection have same role like dexamethasone? So triamcinolone and dexamethasone.
Shorter action.
Sorry?
Triamcinolone has got a shorter action, I said, when compared to dexamethasone. More risk, more incidence of glaucoma, more incidence of cataract. But at least we have stopped. We hardly use triamcinolone.
I know, but it's almost the same action. Actually, it's almost the same. Shorter period, but it's almost the same. But a lot of complications.
Okay, yeah. So it is the same. The question was about the role. So it has the same roles, but it is we have different more complication with this medication rather than the others. Can we discuss if there is update in the role of anti-VEGF in acute or chronic? I think I asked you this question in era of ACTA.
Acute or chronic,
I think Dr. Girard, you have answered this one.
Acute or chronic what?
CSR.
Oh, okay.
No, that we already answered that question.
We already answered. That's why I have said, So annual study predictors for the fellow eye to develop CSR, example, choroidal thickness. I didn't understand.
Yes, because
annual study predictor for the fellow eye to develop CS.
I think basically the choroidal thickness in fellow eyes of CSCR is all. I mean, most patients with CSCR in one eye have increased choroidal thickness in the other eye. So if you ask a question whether there is a possibility of the disease coming in the other eye, yes. But other than that, I don't think that there is any other predictor.
Okay, this I think I told Doctor for you, Dr. Gridhar, because asking about bilateral CSR and bland BDT. How do you do bilateral BDT, same sessions, or
We do it. We do it same session, one eye, and then immediately treat the other eye.
is there any other one do in a different way? Dr. Patricio, okay.
No. All the bilateral cases I have done, same day, same sitting.
Okay.
Immediately one.
Okay, because before I didn't mention the name because it was not showing any name. So now here, Dr. Fawaz Al-Zwemil, any experience with rifampicin?
No, I have not used it.
Anyone have any experience with Dr. Majdi?
I did long time ago, but I didn't find any results, by the way.
Okay. With glaucoma medication, do we have side effect as having cystoid, right?
Central
in
serum.
macula, CSR in macula.
Yeah. Not CSR. You can
Not CSR. It's macular edema, cystoid macular edema.
Yeah, he's written having CSR in macula.
No.
Cystoid
macular edema you can get.
In macula, not my, yeah. Okay.
Yeah.
Okay, thanks for this one was the question. So now we can go to the last presentation. I think Dr. Fahad, he is not attending, I apologize. Let us go, Dr. Majdi, with your last presentation.
Okay.
And last presentation, I think, Dr. Majdi, it will be
about retinal pigment epithelium detachment.
Yeah, pigment epithelium detachment, BED.
Yes, this is the one you gave me. I mean, I never thought that you will give me this talk, but I like
this topic, Dr. Majdi. I want to hear it from you.
You want to hear it from me? Okay, close your phone, please. Retinal pigment epithelium detachment, it's an interesting topic, and I had this 5 years ago, but I have to update it yesterday because a lot of things have changed since 5 years. Let's speak rapidly. What is the retinal pigment epithelial detachment? We all know that the pigment epithelium and Brooks membrane are adherent, but separation of the retinal pigment epithelium from the underlying Brooks membrane, this is what we call retinal pigment epithelium detachment. How do we see it? OCT now and fluorescein. We used to see fluorescein like pooling of the dye in a certain space, which increases in intensity, but not in size. So it's a diffuse hyperfluorescence with progressive pooling in a fixed space. It does not increase in the size, but increase in the intensity. And OCT gave us a very good clue about the elevation. It's a sharp elevation of the retinal pigment epithelium with underlying clear fluid. So it's actually a separation of the RPE from the underlying Brooks membrane. Nowadays, we have this sign, call it double layer sign. We see each layer separately. And this is what is new in retinal pigment epithelium detachment. This is a huge retinal pigment epithelium detachment, and sometimes we used to see small, medium, but huge one like this. We'll speak about it in a minute. So what are the types of retinal pigment epithelium detachment we have? RPED may be serous, clear space, drusenoid, where coalescence of drusen beneath the RPE or hyaline material. Then fibrovascular retinal pigment epithelium detachment, or what we all know, type 1 CNV or occult CNV, and then hemorrhagic RPE detachment. With the new era of OCTA and ICG, we should know what is going on under the retinal pigment epithelium. Let's speak about serous RPE detachment. Serous retinal pigment epithelium detachment could be a precursor of age-related macular degeneration. It's the classic teaching. It starts by drusen, then elevation of the retinal pigment epithelium sometimes, and we have a clear fluid under the retinal pigment epithelium. In central serous choroidiopathy, as we have seen in the previous presentation, we can have a lot of patients with central serous choroidiopathy and adjacent retinal pigment epithelium detachment because it's the disease affecting the retina because of the choroid. Then we have what we used to call isolated or idiopathic retinal pigment epithelium detachment, as we see in the picture here. But nowadays we call this pachychoroid because once we see RPE detachment in a young age without any reason, we look to the choroid with the sweat source. Nowadays we find thick choroid. So this is two examples of retinal pigment epithelium detachment in a case of CSR, and we have seen nice illustration in the presentation of CSR, but Sometimes the point of leak is just adjacent to this retinal pigment epithelium detachment, or even underlying, like the picture here, the leak is under the retinal pigment epithelium detachment. So sometimes the point of leak is not clearly delineated because it's covered by the RP detachment. But again, RP detachment in most cases of CSC is there. And because of the question we were asked a couple of minutes ago, in the other eye, yes, sometimes we look in the other eye of CSC, we don't find CSC, but we find thick choroid, we find what we call footsteps of CSR, multiple patches of hot spots or retinal pigment epithelium detachment, which means that this eye already had CSC and resolved it, or it will develop CSC. So this is another criteria. If you find in the fellow eye hot spots, which mean RP detachment, or you find spots of RP atrophy, which mean that they had a local RP detachment and then it is resolved. And this is the third type, idiopathic retinal pigment epithelium detachment. We used to call it solitary idiopathic, but nowadays we call it pachychoroid. Why we changed this? Because we see the choroid clearly by sweat source OCT. As we see here, if you have a patient like this coming out of the blue sky, you examine the patient, it's 6/6 vision, and you look and find a very small localized RP detachment. But look at the temporal side of the macula. Look at this. It sounds like this area has lost the outer retinal layers, which means that this area could have an old RP detachment, and then after resolution, you will find RP atrophy. So localized RP detachment with underlying pachychoroid, thick choroid, and dilated large choroidal vessels. And this is what we call pachychoroid pigment epitheliopathy. And these cases, sometimes they develop pachychoroid neovasculopathy. So once the RP is elevated, it sometimes triggers the CNV to grow down there and push more and more the retinal pigment epithelium, and we will have an active CNV. This picture of a patient of 45 years old who came out of the blue sky with this. We don't call it idiopathic anymore. We call it pachychoroid with pigment epitheliopathy, which developed CNV. Also, pachychoroid is the spectrum in CSC. So this is a patient with chronic CSC who had atrophy in the macula, and once the patient comes complaining, we will always accuse the atrophy in the macula. But once the patient is complaining of acute drop on top of chronic low vision, so we will suspect that this patient had something cooking down there. So again, this sign the doctor showed us in his presentation, which is called flat irregular RP detachment. Once we look at this and we find a huge choroidal vessels under it, pushing the choroid capillaris, causing choroidal ischemia, and elevating the retinal pigment epithelium, we have to be careful because something is cooking down there. And most probably this is a CNV, or what we call polypoidal choroidal vasculopathy with a branching vascular network and ending up by a polyp. And we can highlight the large choroidal vessels. Look at the dilated and engorged large choroidal vessel. And this is not an OCTA, this is an on-fast OCT, which we can get deeper to the layer and look at the two large choroidal vessels where they are pushing the choroid capillaris and causing this elevation of the retinal pigment epithelium. About the drusenoid RP detachment, we used to say this is a very bad prognostic sign. When you have confluent drusen with drusenoid RP detachment, hyaline material under the elevated retinal pigment epithelium, again, it could be a precursor of formation of choroidal neovascular membrane. So this is what we call drusenoid RP detachment. We can find huge drusenoid RP detachment, and this is not our spectrum now, but I will show you how huge the retinal pigment epithelium detachment you will never expect. And sometimes you look at this patient was almost 10 years ago, before the era of OCTA, but I'm still following her up. Look at this. When I looked at this patient, I said, would it be only RP detachment? Would it be something down there? Could it be choroidal neovascular membrane? This is her OCT, and that was Heidelberg spectral domain, and we have EDI. We looked at the choroid, but look at the elevated retinal pigment, huge elevation of the retinal pigment epithelium with hyaline material under it and with fluid overlying it in both eyes. Would it be a polypoidal? Because we can see again flat irregular RP detachment around the huge one. So where is the membrane? Where is it? We didn't have OCTA at that time. This is one almost 10 years ago, and I presented this 10 years ago, but I looked at it and I injected her and I followed her up. She had flattening of the retinal pigment epithelium, but unfortunately, after flattening, you lose all the outer retinal layers with severe thinning of the RPE. So this could be occult membrane, or what we call polypoidal, which is not seen, but we can see the hyperreflective material under the huge RP detachment. We all know that type 1 CNV, we call it fibrovascular retinal pigment epithelial detachment, and this is a typical picture of this fibrovascular notched sign, hyperreflective material under the retinal pigment epithelium, which means that there is a serous fluid with turbidity and overlying sensory detachment, and OCTA is conclusive in this 3-dimension. It can give you the lacy pattern of this choroidal neovascular membrane. So again, we can see on fluorescein the retinal pigment epithelium detachment, but OCTA is very good in gluing this and giving you the full picture and the flow inside the retinal pigment epithelium neovascularization. Huge RPE detachment. Here is another example of huge RPE detachment. And we have to take care of this patient because repeated injection sometimes lead to a rip, tear in the retinal pigment epithelium. So cautiously, we inject this patient. We have to monitor this patient because sometimes they resolve, but they come up with sudden drop of vision sometimes. And this is what happens when we inject large thing like this. We get a rip in the retinal pigment epithelium. And I said, we have to be cautious with type 1 CNV with huge retinal pigment epithelium detachment, especially if this retinal pigment epithelium detachment is notched. So we can see here, this is the folded retinal pigment epithelium, and this is a bare choroid. So we can see the rip here, and the retinal pigment epithelium is folded. That's why it's hypofluorescent. And this is the choroid and pooling of the dye through the deroofed retinal pigment epithelium. Also, repeated anti-VEGF injection, as I said, you can get a rip in the retinal pigment epithelium, and this is the edge of the tear. We can see it in here, and we have to be cautious with the notched retinal pigment epithelium because this is the most dangerous part of fibrovascular AMD. The last one I'm going to present is the hemorrhagic retinal pigment epithelium detachment. We used to look at this hemorrhagic, and we used to not be able to see what is underlying because of the shadowing of this dense sub-RPE hemorrhage. But nowadays, with the sweat source OCT, I think we can penetrate through this. But this is blood under the retinal pigment epithelium detachment, and the signal from the underlying structure is completely noised. We don't see it, but we anticipate because of the fluid, because of the hemorrhage, that there is choroidal neovascular membrane down there. And here's one of my patients with extensive hemorrhagic RPE detachment. We can see massive subretinal hemorrhage, deep and sub-RPE hemorrhage, and we can see also here clearing hemorrhage, or what we call dehemoglobinized blood under the retinal pigment epithelium. I will show you the OCT in a minute. Look at the OCT. Where is the choroidal neovascular membrane? It's very unusual. And unfortunately, we don't have ICG in our country. So we have to rely on OCTA. And look at this. I have to take OCTA in the center. I have to take OCTA in the peripapillary area, because we always know that PCV always is formed in the peripapillary area, but it doesn't prevent that PCV can be even in the macular area. So this is a branching vascular network ending by small polyp. This is a huge branching vascular network ending by large polyp in the peripapillary area. So we have two components, one under the macula and one in the peripapillary area. So again, this is a polypoidal choroidal vasculopathy with a branching vascular network with multiple polyps, and it can lead to this hemorrhagic retinal pigment epithelium detachment. Would this patient respond sometimes? I think they will. This is another patient of mine who had huge retinal pigment epithelium detachment with massive hemorrhage underlying, exudative detachment surrounding, and after repeated anti-VEGF injection, we can say that the retina is flattened, even the RPE is flattening. We didn't get any rip or tear, but still the visual prognosis is not that good because of the massive hemorrhage in the macular area and destruction of the outer retinal layers. So again, they respond, but we have to be meticulous and careful by repeated injection in these patients. But again, once you see hemorrhagic retinal pigment epithelium detachment, you have to anticipate polypoidal. You have to be careful to look for this polypoidal, and you can find it by OCTA. But sometimes OCTA at the time of presentation with this marked elevation, you'll have a lot of artifact. But I did many OCTA to get this branching vascular network. And after flattening, it's easier to delineate this branching vascular network. So it took me about 10 or 12 times to repeat the OCTA for this patient to delineate where is the polypoidal lesion. And after flattening, it's easier, much easier to find out where is the branching vascular network. It's completely dry with like a trunk appearance. There's dead tree. There is no more activity in these cases. So my take-home message is RPED is a prominent feature of many chorioretinal diseases, as we have seen: wet AMD, dry AMD, CSC, pachychoroid, PCV, and development of CNV has been associated with long-standing PED. And nowadays we can see any patient with flat and irregular RP detachment, we suspect that there is an choroidal neovascular membrane down there. It doesn't matter if it's a PCV or early CNV, but you have to check any flat irregular RP detachment. And it's very important to identify specific feature and nature of the detachment of the retinal pigment epithelium and to establish accurate diagnosis and treatment plan to avoid complications as we see like the rip in the retinal pigment epithelium. Thank you so much for your listening.
Thank you very much, Dr. Majdi. This is what I was waiting to listen for you. It's
I hope I satisfied you. I hope I satisfied you.
Excellent, as usual. There is no doubt about that.
Thank you.
Thanks a lot. And we are sorry for dear friends in India, Dr. Shobit Chawla and Dr. Giridhar. It is too late for them. I know it's now around 1 o'clock midnight. So we want to, if they want to leave, it will be okay for us. It's okay. Thanks a lot, Dr. Shobit. Thanks a lot, Giridhar. Good night. We'll see you, inshallah, other session in the next day. Thank you very much.
Thank you, everybody.
No, not for you. Majdi, you are not going.
I'm staying. I'm staying.
Yeah, you are staying. This is only for India. Only excuse for India.
I didn't have my dinner yet.
That's why you have to wait.
Okay.
Okay, Doctor, I know there is a lot of question in mind, Dr. Patricia. Please go ahead.
No, Patricia is my friend. He was not going to ask me anything.
Yeah, he'll ask you only one question.
I completely agree with Professor Makti. I mean, RP are still challenging in the 21st century, and we are without any power, just watching how the RP flattens many times and leaves behind an area of chorioretinal atrophy, and the patient gets legally blind. Yep. So I wish we could treat this many times in RPEDs with no choroidal neovascularization underneath, that we cannot do anything for them. And that's I think one of the take-home messages. If you cannot identify any choroidal neovascularization, you should not treat these cases with anti-VEGF. What do you think, Professor?
I totally agree, because I spend many times in this patient doing OCTA. If I have an ICG, I would do it in a second, and I would find out if there is anything down there like a plaque or CNV or hyperactivity. But in our country, I use OCTA, and I spend a lot of times with this patient. You know how much bad fixation they have, how much elevation of the retinal pigment epithelium, how much artifact we have. But once I find any clue that there is a CNV down there or a PCV, I would start treating this patient. Otherwise, it's a risk to treat this patient. And telling you the truth, the patient I showed with the huge retinal pigment epithelium attachment, I injected her for 3 times. She did not improve. But after 6 months without treatment, she flattened. But she lost the vision. She has counting finger in one eye and 660 in the other eye.
Yes, yes.
I think this is the challenging how to treat this patient. This is the problem of dealing with pigment epithelium detachment, retinal pigment epithelium detachment. Okay, Dr. Brasani, if you have any questions, if you are still there. Anyway, just this is an announcement for dear friends and participants. Thanks for them for staying with us for the whole day today from 5 o'clock till now. Thanks for all of them. There is a lot of people that are listening to us now here, and there are different sessions. We reach our registration 2,000 by 2,000 attendees in different sessions. Thanks for all of them. We are having many attendees in Facebook and YouTube. Thanks for all. And tomorrow we'll see you, inshallah, by 3 o'clock UAE time. We'll start our session, and we have a very interesting sessions. We wait to see you all there, inshallah. For the time being, I would like to thank you all. Thanks, Dr. Majdi. Really, all the times I am pushing and behind you. I would like to apologize for any inconvenience. And only one time I will apologize, not every time. My dear friends, Dr. Patricio, it's my pleasure. It's to be with us. Thanks also, Prasan, Dr. Shaula, and Dr. Giridhar, Dr. Vishali. We missed Dr. Fahad Kohel. I don't know what happens. He couldn't be with us today in this session. Maybe we'll see him in the other. I hope that he was with you in OCTA.
He was there and he stayed to the end, but probably
maybe have something to do, and there is something in the work. And I don't know, there is questions, Dr. Majdi. I don't know how to prevent rip of PED. See?
You can put your thumb on the retinal pigment epithelium, so you flatten it without intravitreal anti-VEGF. It's not. It's inevitable. I mean, but be cautious. In these cases, I don't do loading doses. I give one by one. I give one injection and see the response, another injection and see the response, and follow up the patient meticulously. Every month I do OCT for him to see how flattening it is. If any sign of notch, increasing the notch in the fibrovascular RP detachment, I would pray for that the rip will not fall. But with all these precautions, still you can get a rip of the retinal pigment epithelium. But again, be cautious. Don't give 6 loading doses. Give one by one. Once the retina is flattened, you should stop injection in this patient, because you can win or lose depending on how many injections they give. But again, no way to prevent. It's inevitable in some cases, and you'll never anticipate which one will have.
Thank you, Dr. Majdi. That question was from Dr. Abdelbari Al-Sharif. Thank you, Dr. Abdelbari, for these questions. Are highlighting a very important point, actually. Regarding the previous topic, which non-steroidal anti-inflammatory you prefer in both cataract CME, Nevinac or ketorolac? We don't have here ketorolac, Dr. Patricia, right? We are having only Nevinac, right?
We have of these two, we have Nevanac, yeah.
Nevinac, yeah.
Yeah, I have experience with ketorolac anyhow from Spain. If the patient is not diabetic, I don't mind any of them, ketorolac or Nevanac. If the patient is diabetic, I could go for Nevanac.
Yeah.
Okay.
We have both of them, but both of them actually they work. Both of them work.
Yeah.
Okay. Question for Dr. Majdi for a direct and short answer. Dr. Majdi, you want to go to sleep, I know. First of all, thanks, Dr. Majdi, for a nice talk. How aggressive you are going in treating serous pigment epithelium detachments?
No, I don't treat it. I mean, if it's a serous retinal pigment epithelium detachment, I don't treat, because it's a just elevation of the retinal pigment epithelium. But again, do OCT follow up and see any sign of progression of this. If more elevation, if they develop sometimes RP detachment with overlying minimal fluid. Sometimes you get serous detachment overlying the RP detachment. So it means that there is something leaking from the under the retina, and sometimes you miss a choroidal nevus membrane. In these cases, once I find the RP detachment is progressing or patient is developing sub-retinal fluid, I would do OCTA to delineate any sign of CNV. Probably this patient would have a polypoidal, not a CNV, and sometimes it's very tiny. It doesn't show any manifestation at the beginning, so OCTA could be a clue in this case. But I would never treat a patient with only retinal pigment epithelium detachment.
Yeah,
Thank you very much, Dr. Majdi. Yeah, Dr. Patricia, go ahead.
Don't get a printout when you order an OCT or an OCTA. Go and scroll down all the whole area.
Yes.
Because you can find something that it is not in the printout the technician is giving to you.
Multiple line scans or scanning the whole cube, that would give you a very good clue if you need to make sure there is a CNV or not.
See, I think the company, they are calling me, they will kill me because I'm exceeding the time by 30 minutes. Okay, anyway, but with Dr. Majdi, I don't mind, and Dr. Patricia. Dr. Majdi, don't take it as a promise.
No, can I say something?
Yes.
I would like to thank Dr. Al-Amri. Really, he did a lot of job. He called me about 12 times. He keep asking me, what can we do this? What can we do? He is very meticulous in doing the program. And I know you have a hard time calling the people, getting the company. But I think this is a very good work. And I wish I'd been there in Emirates as we used every year. But I'm glad to be with you virtual. And thank you so much for your effort. And I really appreciate it because I know how much effort you did to get this picture coming out to the audience. Thank you so much.
Thanks a lot. No, thanks. It's our pleasure and honor, Dr. Majdi, all the times as usual. And Dr. Patricio, thanks for all of you, and good night for today. And we'll see you inshallah tomorrow.
Inshallah. Goodbye, Patricio. Goodbye.
Bye.